In this second part of the lecture, we will look at chronic gastritis and its complications, especially related to Helicobacter pylori, autoimmune atrophic gastritis, and peptic ulcer disease. We will also briefly look at hypertrophic gastropathies, namely Zollinger-Ellison syndrome and Menetrier disease. Chronic gastritis is chronic mucosal inflammatory changes leading to mucosal atrophy and intestinal metaplasia. The epithelial changes that can be seen in chronic gastritis is dysplasia that progress to carcinoma. Symptoms associated with chronic gastritis are typically less severe but more persistent. Two types of chronic gastritis that we will look into is chronic infection by Helicobacter pylori, which is the most common cause of chronic gastritis, and autoimmune gastritis. Almost all patients with duodenal ulcers and most patients with gastric ulcers or chronic gastritis will have Helicobacter pylori. Acute Helicobacter pylori does not produce sufficient symptoms to come to medical attention. It is the chronic gastritis that ultimately causes the individual to seek treatment. Helicobacter pylori are present in the majority of individuals with chronic antral gastritis. H. pylori has a few virulence factors such as flagella, urease, adhesins, and toxins such as cytotoxin-associated gene A. H. pylori infection is associated with poverty, household crowding, limited education, residence in rural areas, and age over 60 years old. Humans are the primary carriers, suggesting that transmission is primarily by fecal-oral route. Infection is typically acquired in childhood and persists for life without treatment. Improved sanitation explains the marked reduction in H. pylori infection among younger people. In well-resourced countries, H. pylori infection is currently uncommon before 10 years of age and is found in only 10% of those between the ages of 18 and 30, but is present in up to 50% of those older than 65. Helicobacter pylori infection most often presents as predominantly antral gastritis with normal or increased acid production. When inflammation remains limited to the antrum, increased gastric production increases the parietal cell mass within the gastric body, and this increases acid secretion, which can lead to gastric ulcer or duodenal peptic ulcer. Alternatively, long-standing H. pylori gastritis may involve the gastric body and fundus, resulting in atrophic gastritis with reduced parietal cell mass, intestinal metaplasia, and this may lead to adenocarcinoma. Again, you see the organism here on Watin-Starry silver stain, and you see there's lymphoid aggregates. This lymphoid aggregates is strongly related to Helicobacter pylori gastritis, and it can potentially transform into a lymphoma. Intraepithelial and lamina propria neutrophils can be prominent in this case. Diseases that are associated with H. pylori includes chronic gastritis, peptic ulcer disease, gastric carcinoma, and gastric lymphoma. In addition to histologic identification of the organism, several non-invasive diagnostic tests can be done, including serology for antibodies to H. pylori, fecal bacterial detection, urea breath test, which is positive due to ammonia produced by the bacterial urease. Immune atrophic gastritis, in contrast to H. pylori associated gastritis, typically spares the antrum and is often associated with marked hypergastrinemia. It accounts for less than 10% of cases of chronic gastritis, and it is characterized by antibodies to parietal cells and intrinsic factor, reduced serum pepsinogen 1 concentration, endocrine cell hyperplasia, vitamin B12 deficiency, and defective gastric acid secretion or achlorhydria. It is associated with other autoimmune diseases such as Addison disease, type 1 diabetes mellitus, and Hashimoto thyroiditis. Autoimmune gastritis is associated with loss of parietal cells, which reduce the secretion of gastric acid and intrinsic factor. There is absence of acid production, and this stimulates gastrin release, resulting in hypergastrinemia and hyperplasia of antral gastrin-producing G cells. Over time, G cell hyperplasia can progress to neuroendocrine tumor. There is lack of intrinsic factor that disables ileal vitamin B12 absorption, leading to B12 deficiency and a slow onset megaloblastic anemia. The reduced serum pepsinogen 1 concentration results from chief cell destruction, and the loss of parietal cells and chief cells causes mucosal atrophy. In contrast, although H. pylori can cause hypochlorhydria, it is not associated with achlorhydria or pernicious anemia. The principal agent of injury in autoimmune atrophic gastritis is CD4 T cells directed against parietal cell components. There is no evidence of an autoimmune reaction to chief cells. Thus, the chief cell destruction or loss is due to the autoimmune attack on parietal cells. There are autoantibodies to parietal cell components such as hydrogen potassium ATPase or proton pump and intrinsic factor. Autoimmune atrophic gastritis is characterized by diffuse damage to the acid-producing mucosa within the body and the fundus. The antrum and cardia are typically spared. With diffuse atrophy, the oxyntic mucosa appears markedly thinned and the rugal folds are lost. So here you can see there are a lot of inflammatory cells within the gastric body, and there are glandular atrophy. And you can see goblet cells here, which indicates intestinal metaplasia. Rarely, endocrine cell hyperplasia may progress to neuroendocrine tumors. Autoimmune gastritis affects slightly more women than men. They are often associated with other autoimmune diseases. They may present with anemia, vitamin B12 deficiency, and neuropathy. There are risk of carcinoma and neuroendocrine tumors, such as carcinoid tumor. Chlorhydria of gastric mucosa may permit overgrowth of bacteria that produces carcinogenic nitrosamines, which may increase the risk for carcinoma progression. Peptic ulcer disease refers to chronic mucosal ulceration affecting the duodenum or stomach. It is almost always associated with H. pylori infection, NSAIDs, or cigarette smoking. The most common form of peptic ulcer disease occurs within the gastric antrum or duodenum as a result of chronic H. pylori-induced antral gastritis. It is most common in gastric antrum and the first portion of the duodenum, and male is affected more than females. There is imbalance between gastroduodenal mucosal defense and insult by gastric acid and pepsin. There is also a superimposed injury by environmental or immunologic agents. The mucosal defense are via surface mucus secretion, bicarbonate in the mucus, mucosal blood flow, apical epithelial transport system, epithelial regeneration, and the production of prostaglandin. Factors that can impair the stomach defense mechanism includes H. pylori, ischemia and shock, delayed gastric emptying, and duodenal gastric reflux. Other promoters are factors that can increase gastric acidity, such as gastrinoma, Zollinger-Ellison syndrome, and NSAIDs that suppress mucosal prostaglandin and bicarbonate production in the mucus. Other factors includes smoking, alcohol, cirrhosis, corticosteroid, and hypercalcemia. You can see here Helicobacter pylori cause peptic ulcer disease by increasing the gastric acid production and reducing the bicarbonate production within the mucus. Helicobacter pylori causes epithelial cell injury and inflammation that causes injury to the mucous cells, which impair their protection of the gastric mucosa. Helicobacter pylori also can cause thrombotic occlusion of capillaries by platelet activating factor, and that also reduces the rich mucosal blood flow. Just now, gastrinoma increase the gastric acid production, and that can cause peptic ulcer disease. Prolonged use of NSAID and corticosteroid reduces the ability of the mucous cells to produce prostaglandin, and that will reduce the mucus and bicarbonate secretion. That will increase the hydrogen secretion, and that can also cause vasoconstriction, which reduces the mucosal blood flow. Smoking can also impair mucosal blood flow. Peptic ulcer can be differentiated from the malignant gastric carcinoma ulcer. It shows a sharp punch-out defect. The margin is not elevated, and there is overhanging mucosal border with smooth, clean ulcer base. This is another representation of the peptic ulcer. You can see the punched-out ulcer with inflamed mucosa usually, and the ulcer base is usually clean. Yeah, compare that to the gastric carcinoma ulcer. It's clean because there is a lot of gastric acid and pepsin, which is removing the necrotic cells. Yeah. Another representation of peptic ulcer with gastric mucosa margin, and you can see the base of the ulcer, and this is the muscle. Okay, so it's important to differentiate benign and malignant ulcer by endoscopy, and usually the surgeon will make a lot of biopsy to distinguish the two regions. Peptic ulcer disease presents with epigastric burning or aching pain, which occurs 1 to 3 hours after meals during the day. The pain is worse at night and is relieved by alkali or food. Sometimes there are nausea, vomiting, bloating, belching, and significant weight loss. With penetrating ulcers, the pain is occasionally referred to the back, the left upper quadrant, or the chest, which may be misinterpreted as cardiac in origin. The complication of peptic ulcer disease is bleeding, perforation, and obstruction from edema or scarring. At complications of chronic gastritis, there are two major ones that we'll look at: mucosal atrophy and intestinal metaplasia. And the second one is dysplasia. Chronic gastritis may lead to significant loss of parietal cell mass, and this is frequently associated with intestinal metaplasia, recognized by the presence of goblet cells, and this is strongly associated with increased risk of gastric adenocarcinoma. This risk of adenocarcinoma is greatest in autoimmune atrophic gastritis. This may be because a chlorhydria of gastric mucosal atrophy permits overgrowth of bacteria that produce carcinogenic nitrosamines. Intestinal metaplasia also occurs in Helicobacter pylori gastritis, but this may reverse after the clearance of the organism. Chronic gastritis exposes the epithelium to free radical damage and proliferative stimuli. Over time, this combination can lead to accumulation and amplification of genetic alterations. that result in carcinoma. Pre-invasive in situ lesions can be recognized histologically as dysplasia, and as we have seen before, the morphologic hallmarks of dysplasia includes variations in epithelial size, shape, orientation, chromatin texture, hyperchromasia, and nuclear enlargement. Menetrier disease is a rare disorder associated with excessive secretion of transforming growth factor TGF-alpha and hyperactivation of the epidermal growth factor receptor on gastric epithelial cells. It is characterized by diffuse hyperplasia of the foveolar epithelium of body and fundus and hypoproteinemia due to albumin loss across the gastric mucosa. There are secondary symptoms which are commonly present, such as weight loss, diarrhea, and peripheral edema. There is a higher risk of gastric carcinoma in adults with Menetrier disease. So you can see that in the picture, the disease grossly is characterized by the irregular enlargement of the gastric rugae, and the rugae are present in the body and fundus, but the antrum is generally spared. There is the hyperplasia of the foveolar mucous cells histologically. Zollinger-Ellison syndrome is caused by gastrin-secreting neuroendocrine tumors or gastrinoma, most commonly found in pancreas or small intestine. Patients often present with duodenal ulcers or chronic diarrhea. Gastrin regulates growth of gastric epithelium, so excess of gastrin causes hyperproliferation of gastric glands, and this increases the number of parietal cells, and patient will become hyperchlorhydric. 60 to 90% of gastrinomas are malignant.